lecture will be delivered by Dr. Miguel Valderra bano. Dr. Valderra bano is a very accomplished electrophysiologist. That is a cardiologist that studies heart rhythms. So he is an expert in heart rhythms. He is a very busy clinician, a very busy doctor. He's a very skilled doctor. He studies heart rhythms. And he also is a researcher. There's very few people that can do both, that take great clinical care of patients and that can do great research. His research is very innovative. He's funded by the National Institutes of Health. I don't know if we're going to be hearing about that work, but very superb work to understand the mechanisms of heart irregularities. So he's going to talk to us now. His title is When the Heart Flutters, How Atrial Arrhythmias Affect Women. Dr. Valderra bano, a pleasure to have you here.
Thank you. Thank you, John. All right, so as John said, I am a heart electrician, and you've heard a lot about heart attacks earlier today and how they affect women. You can divide heart disease as plumbing issues or electrical issues. And when I started as a fellow, the heart's electricity was something that clearly fascinated me. How do you get a piece of meat the size of the heart to squeeze all at once? And the way biology has solved that problem is by creating a network of wires that coordinate an electrical impulse that spreads through the heart and creates a heartbeat. So this is how a normal heart looks in normal rhythm. We have a natural pacemaker that is located here called the SA node. It's a natural pacemaker, just like artificial pacemakers. It just fires electricity every heartbeat. And when it fires electricity, electricity spreads through the upper chambers, and then through the upper chambers, it gets then funneled to the lower chambers through a specific wire called the AV node. In normal rhythm, electricity spreads first through the upper chambers. That makes the upper chambers contract. And then it goes to the lower chambers and makes the lower chambers contract. So normally there's a sequence, first the upper chambers and then the lower chambers. That's very important for optimizing the filling. The plumbing depends on the electricity. So to optimize the plumbing, the filling of the lower chambers, you need to have this kind of sequence of first the upper chambers and then the lower chambers. The problem is things can go awry. And this is one example where electricity can get messed up in the lower chambers. If electricity gets messed up in the lower chambers, that is called ventricular fibrillation. The lower chambers don't pump, they just quiver, and you die. That's called sudden cardiac death. Fortunately, that's rare, and that is not going to be the topic of my talk. We're going to concentrate on electrical disturbances of the upper chambers, atrial arrhythmias, which are also more of a problem in terms of healthcare and that have particular issues that pertain to women specifically. So the upper chambers can have all kinds of disorganized electricity or abnormal electricity. The most common is atrial fibrillation, something that was alluded to earlier. It's an irregular rhythm. It's disorganized electricity in the upper chambers. Then you can have different forms of electricity spinning. It's called reentry in a technical term. And electricity can spin around certain normal anatomical structures. So you see the AV node. This is the natural wire that takes electricity from upper chambers into lower chambers. Electricity can start spinning around this area. That's called AV nodal reentry, much more common in women than in males. This happens about 70 in patients with this condition, AV nodal reentry, which leads to rapid heartbeats, usually at a young age in young women. It happens in 70% of the patients with this condition are women, 30% are men. You could have been born with an extra wire. Say you have another extra wire here, electricity can spin going down the normal wiring and up the abnormal wire. That is equally prevalent in males and females. And then you may have spots that fire electricity out of sync, the so-called atrial tachycardia. The interesting thing is that most of these arrhythmias come and go. So I heard earlier in the question and answer session that patients may complain of, well, my heart was fluttering or I felt my heart pounding. You go to the doctor, everything is fine. just because you go to the doctor and everything is fine doesn't mean anything. I like to tell the patients the stories of how many times have you taken a car to the mechanic to fix some noise that the car makes, and then you try to show it and it doesn't happen. You may show up to the doctor and your rhythm may be perfectly normal, in which case the doctor is not like they're not wrong in saying everything is normal. They are wrong in dismissing you because this requires monitoring to document. So as long as you're having symptoms, you may need to explore the situation until you catch one of those episodes. And we do that by prolonged monitoring. So we have people wear little stickers in their chest connected to a cell phone that records the rhythm for a prolonged period of time so that we can catch the episodes. And when we catch the episodes, it's obvious. For us, it's obvious. We see the abnormal electrocardiogram, and then we can figure out what's going on. So key take-home message is just because everything is fine when you go to the doctor, it doesn't mean you don't have an electrical problem. But let's focus on atrial fibrillation, which is the most common arrhythmia in adults. Like I said, it tends to be a rapid and disorganized rhythm in the upper chambers. And this cartoon is pretty accurate in that most commonly it starts with firing of electricity from one of these 4 tubes. These are the tubes that connect the heart with the lungs. So oxygenated blood comes from the lungs and connects to the heart in one of these 4 tubes. So the left lung connects here, the right lung connects here. For reasons we don't really understand, abnormal rapid firing from these veins leads to electricity spreading, and as it spreads, it kind of breaks down and it starts making these inconsistent activation patterns. You see this goes counterclockwise and then clockwise, so there's no consistent activation pattern in the upper chambers, and the lower chambers just follow. Several things that are very important. You don't feel the AFib. You don't feel the upper chambers quivering. What you feel is the lower chambers trying to catch up with what the upper chambers are doing. Remember, the lower chambers get electricity through this wire and then beat. And they only beat when they get a signal of electricity coming from the upper chambers. When you're in AFib, your upper chambers may beat at 500 beats per minute, so super fast. Now, you don't feel those 500. What you feel is out of those 500, every third, every 10th, every other beat goes to the lower chambers. So you feel your pulse rapid and irregular. The irregularity is key. That you have, boom, 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 like that. And that is extremely unpleasant to most people. Some people don't feel it at all. And we'll talk about how symptoms can be different in women and men. But most commonly is a very unpleasant feeling of rapid and irregular heartbeats and pulse. If they check your pulse, it's rapid and irregular. And that's what leads to symptoms. But there's something more important, perhaps. The upper chambers beat so fast that they don't have a meaningful contraction, they just quiver. Instead of having a nice contraction, kicking blood into the lower chambers, they just quiver. And the upper chambers, particularly the left upper chamber, has this pouch. This pouch is like a big toe or, it's a sac attached to the left upper chamber. This sac normally takes blood and then squeezes blood back. And it's part of the mechanical function of the upper chamber. But when you're in AFib, it just quivers. And when it quivers, it doesn't move blood. And blood can be very stagnant there. And what happens when blood is stagnant? It can form a clot. If a clot forms, it can go to your brain and give you a stroke. Next thing you know, you can't move your arm, you can't speak. So that is the most dreaded complication of atrial fibrillation. And as we will see, it's more common in women than in men. Atrial fibrillation is a disease of aging. If you look at the prevalence of atrial fibrillation across the different ages in lots of studies looking at community studies and large populations, you can see how the prevalence goes up with age. And for people older than 80, up to 15% of the patients, 15% of patients older than 80 have atrial fibrillation. And this is not the kind of AFib that comes and goes. We talk about persistent atrial fibrillation, and we'll talk about the different kinds. So if aging is a key factor in determining the prevalence of atrial fibrillation, with the aging of the population, we can only expect that the overall prevalence of atrial fibrillation in the community, this is projected up to 2050, the overall prevalence of atrial fibrillation is going to increase. As we do a better job keeping people alive, then we're going to have to deal with problems of aging, and atrial fibrillation is one of them. How does sex affect atrial fibrillation? So this is kind of complex. Overall, men have 1.5 times the incidence of atrial fibrillation compared to women. So you could say, okay, so this is more common in men. It is, but it's interesting that the prevalence with age gets a little bit more even. This is looking at the incidence per 1,000 persons per year, looking at different races, Hispanic, Asian, black, and white, and at different age groups, and separated as men and women. So women tend to have less incidence than men. That's particularly so in younger individuals, 65 to 69. We used to now consider 65 to 69 young, which is nice. As you get older, the incidence kind of evens out. There's still a little bit more incidence in males than females, particularly in white individuals. But it's interesting. If you look at the lifetime incidence, so if you look at, okay, I'm here, I'm whatever, 45, what are the chances that throughout my life I get AFib? 1 in 4. 1 in 4. So of all these people that are in this auditorium, 1 in every 4 of you will develop atrial fibrillation. That's kind of scary. And the interesting thing is that that is the same for males as it is for females. So how do you reconcile what I just told you earlier, that the incidence is more in males? Just what happens is that females tend to get it later in their lives. So if you look at the cumulative risk of atrial fibrillation in males, sure, with age, the colors are different races, but with age it goes up, but it starts ramping up in mid-60s, 70s. In females, it starts later. This is very important, because by the time a female gets atrial fibrillation, she is older, she is sicker, she has other comorbid conditions, and very importantly, she is less likely to be a candidate for invasive treatments, which is what cures atrial fibrillation. So that is a problem. So let me spend some time just illustrating the downstream problems of atrial fibrillation. Of course, atrial fibrillation is associated with an increased risk of death, also heart failure, also myocardial infarction. Now, some of that may be related to clots that developed in that little pouch that as they travel out of there, just as they may get pumped to the brain, they may get pumped to the coronary arteries and give you what is called an embolic infarct. But also because the pre-existing conditions that lead to atrial fibrillation, which is aging, hypertension, smoking, and others, obesity and sleep apnea, those conditions also increase the risk of coronary artery disease. So electrical problems and plumbing problems kind of come together the older you get. Now, why gastrointestinal bleeding? How is this happening with atrial fibrillation? Nothing that I explained to you had anything to do with bleeding in your stomach. Well, you have to keep in mind, what do we do to prevent strokes? What do we do to patients to prevent clots from forming in that pouch? We give them blood thinners. The problem is, blood thinners work great. Blood thinners would thin the blood and would prevent clots from forming in that little pouch. The problem is those blood thinners don't just act in that pouch. They act everywhere in your body. So if you have a small ulcer, if you go out and eat a bunch of tacos and you get heartburn and you get a lot of acid in your stomach and next thing you know you have a small ulcer, you're more likely to bleed if you're on blood thinners. And if you're on blood thinners with enough dose to prevent clots in the appendage, in the pouch, you will be on enough dose to bleed in your stomach. And those bleeds can be very substantial. So let me, some technical definitions about atrial fibrillation, which I briefly alluded to, but I think it's important to understand. Paroxysmal AFib is AFib that comes and goes. It's a kind of AFib that, as I will describe, patients will have palpitations. I felt my heart racing for a few minutes to half an hour. I went to bed, woke up, I was fine. And then you go to the doctor, everything is fine. That's the paroxysmal AFib that many times goes undiagnosed for years. You know, one time after 10 years of feeling palpitations, finally the patient shows up in atrial fibrillation in the emergency room or in the clinic. You pick it up on the EKG. There you have your diagnosis. Now, with the retrospect you may say, you know what, you've had this for 10 years. It just is the first time we pick it up. The interesting thing is, when it comes to the risk of stroke, there hasn't been, we have not shown any difference in the incidence of stroke, whether you have AFib all the time or coming and going. When you have AFib coming and going, if you have enough AFib episodes, the times that your heart is going in atrial fibrillation, beating at 500 beats per minute, create a weakness in the heart muscle so that even when it goes back to normal rhythm, it's not just as strong as it was before. So you remain at risk of stroke. It's very tricky. You see the consequences of AFib even after AFib has happened, even after the patient is in normal rhythm. We see it very commonly when we shock someone out of atrial fibrillation. So sometimes the patient shows up in atrial fibrillation and is going with a heart rate of 160, very symptomatic. We say, okay, we need to shock you out of atrial fibrillation, put you back in normal rhythm. Sometimes you can shock the patient out of atrial fibrillation, put them back in normal rhythm, and unless you give them blood thinners, they have an increased risk of stroke after you restore normal rhythm because that pouch will not have a normal contraction for a few weeks. So persistent AFib is the one that persists more than 7 days. We have this arbitrary cutoff. Long-standing persistent AFib is that stays continuously for 1 year. Permanent atrial fibrillation is the kind of AFib that the doctor and the patient decide we're not gonna treat it. We're gonna let you be. We're gonna focus on making sure your lower chambers don't go too fast, making sure you don't get a stroke. Why should we do that? Well, in some patients, aggressive therapies or drug therapies for AFib are not worth it. They have too much risk, too much toxicity. I mean, if the patient has a heart rate in the 80s or 70s at rest, we're fine. So let me just emphasize again the differences in symptoms by different genders. So women tend to have less palpitations than men. You know, it's interesting because as far as AFib, women are less, men are more whiny than women, okay? Men complain more about palpitations. Women will complain of weakness, shortness of breath, non-specific stuff, and that may be why sometimes we delay the diagnosis. What's worse, sometimes stroke may be the first presentation of atrial fibrillation, and that's a disaster. So what do we do when we want to get rid of atrial fibrillation? There's a few things, there's a few drugs that work about 50% of the time. At best, they suppress AFib. But thinking back of this mechanistic paradigm of rapid firing from the pulmonary veins, a procedure was devised now in 1998, so 20 years ago, that consists in burning or cauterizing, ablating the pulmonary veins, so getting rid of electricity from this part of the heart, with the goal to improve symptoms. And the problem is, do we know that we improve the outcomes? Do we know that if I cure AFib by burning these spots, I protect the patient against strokes? We don't know that. We do not know that. So the goal with ablation, the procedure is called ablation, is number one, symptom suppression. And we have, again, we have studies looking at whether we can reduce stroke and improve mortality, but we don't know that yet. There are many approaches. Most of them consist in different degrees of burning the back of the left upper chamber. The idea is to get rid of electricity from these 4 tubes that connect the heart with the lungs. And there's a lot of theories as to how it works. I could bore you with the details. What you can take home is that when it comes to symptoms, ablation is much better than any drug we know. This is one study of many showing that 1 year after ablation, here 9 months, 80% of the patients had control of the symptoms, whereas 20% after ablation, whereas only 20% after drug had control of the symptoms. So clearly, it's much better than any drug we have. And some people advocate ablation as the first line of treatment, which is controversial. When I see a patient and I talk about ablation and they have not been treated for atrial fibrillation with a drug, they walk out completely scared about the stuff that I tell them about procedural risks and about what it entails. You know, I'm going to get into your left upper chamber. I'm going to punch a hole in your heart and then burn. I've had 2 people pass out in my office. The thing is, when they have a couple of episodes of AFib, they come back and they say, we're ready, whatever you say. So let me just explain how AFib ablation is different in women. Well, it's like you guys got the bad deal here. There is less success when you look at freedom from atrial fibrillation in males in the gray and women in black. Less success, less freedom from atrial fibrillation and antiarrhythmic drugs. Slightly more complications overall, particularly moderate complications. So not mortality of the procedure, but when we burn these tissues in the pulmonary veins, we have to make contact between a catheter that has a metal tip that actually burns and the tissue. To get the job done, we need to make contact. If we make too little contact, we don't get the job done, the procedure fails. If we make too much contact, we may tear the muscle. And if we tear the muscle, it will bleed in the sac that's around the heart. I hope nobody passes out if I tell you. And we have to stop the procedure, and I have to drain the blood from the outside of the heart. It's something we have to deal with, but women tend to have more friable tissues, less robust when it comes to poking with a catheter. A few words about stroke. So this is the pouch that I was alluding to. This is an image from transesophageal echocardiogram. And this is the pouch, and this little ball here is a clot that has formed in there because that pouch was just quivering. It wasn't squeezing blood, and blood was stagnant. It's a cul-de-sac there, and that's the reason why patients get stroke. It turns out that, again, stroke goes up with atrial fibrillation, and so does mortality. Interestingly, this has been attributed to strokes, but dementia, incidence of dementia, is much higher in patients with atrial fibrillation. We don't know if that's related to subclinical stroke. This is the dementia, the patient shows up age 75 and they're having memory problems and they've never had a history of stroke, but the memory problem is there. Well, that kind of situation is more likely to happen in patients with atrial fibrillation. We don't know exactly why, we're actively working on that. But when it comes to actual strokes, women have a higher risk of stroke. And it's really not known why. It may be because women with AFib tend to be 10 years older statistically than males with AFib, so therefore they have more comorbid conditions, more hypertension, more left upper chamber enlargement, less contractility within AFib. Some patients in AFib where the heart is quivering, they may retain some degree of contractility in that pouch that may be at some level protective, but some others, they don't. And this is actually one of the biggest challenges for us in this field, figuring out how to really predict who is going to have a stroke with atrial fibrillation, because we put all these patients on blood thinners. We expose them to a 3 to 5% risk of bleeding every year due to these blood thinners, and not all of them get a stroke. So to summarize, atrial fibrillation and the overall differences by sex. Risk factors are different. Women will have more hypertension, more valvular disease, in general more obesity, less coronary artery disease, less lung disease. And there's some hypotheses that there may be genetic or endocrine reasons for that. There may be some electrical differences in women compared to men, minor. In general, some women tend to have what we call long QT induced by drugs more likely than men, but there's subtle electrical differences that may justify it. What we call less lone atrial fibrillation. Lone atrial fibrillation means that the heart is otherwise fine, that the hardware is just fine, it's just an electrical problem. That is more common in males than in women. Women, when they have AFib, they tend to have enlargement of the left upper chamber, hypertensive disease, and others. And there may be some health care delivery problems. There may be that we doctors are less aggressive with females than we are with men. We obviously try to avoid that. I don't deny that there may be some subconscious prejudice against aggressive treatment in women. In some doctors, we obviously don't have that. We strive not to have that, but it may be there. One of the issues that we had, John Cooke alluded to the clinical trial that we have with the NIH-funded study. The NIH is funding the study, and they really insisted on equal enrollment of females in our study. This is a study for ablation of atrial fibrillation. And what ended up happening was that, we looked at the data, we looked at the first 100 patients enrolled, and only 25% of the patients were female. And I swear to God, I don't refuse ablation. I love ablation, and I love to do ablation in males, females, whatever. But for whatever reason, we had less females. And that's what made me dwell into the reasons. And the reasons are that women are less likely to be candidates for ablation, for the reasons I alluded to, age and other comorbid conditions. So I'll stop there and be happy to take any questions. Thank you for your attention.